So, good afternoon, everybody, and good morning, whenever you are. I'm Dr. Roba Dehni, and me and Dr. Amin Al-Awadi will hold this meeting. So we will start with Dr. Amin. He will give us Kodachrome and interesting lots of cases, and it will be followed by who did the quiz. So we will have the quiz answers after Dr. Amin. So all to you, Dr. Amin. Thank you.
Thank you, Dr. Rauda. Welcome everyone to this exciting new session. I just would like to encourage every one of you who are attending this meeting to, so who attended this meeting to be active with the answers, because the faster we answer and the more we answer and more we interact, we can do more cases. So again, remember, this is all about coming up with a good differential diagnosis and then coming up with a good investigations to reach our diagnosis and make a management plan. So let's start now. First case. What do you see, and what would your the differential diagnosis be for this patient? Hello, everyone hears me? Is
So I
everyone
guess
there?
like depositional.
Okay, so depositional would be in the differential diagnosis. Well, what example would it of a depositional disorder would you think for this patient?
Not slam dunk, but I'll think about like calcinosis.
Calcinosis is not a bad differential. That's a good differential. What else? Could it be neoplastic as well? Focus on these here, erythematous, between skin color to erythematous nodules on the head, single, like multiple lesions on the forehead. Can you think of anything?
I think some people are using the chat group to write answers. I see
Yeah, I can see it now.
neuroblastoma.
So one said self-healing mucinosis. I like that diagnosis. Myofibromatosis. I mean, that could be okay. Usually, myofibromatosis would be more plum colored, or like, more erythematous to purplish. But if it was deeper, it can definitely look like this. So that's also Dr. Mishal, two good differential diagnosis. So mucinosis and myofibromatosis. What? Pilometricoma, yes, that could be correct. Usually pilometricomas are smaller than this, and usually they're single, but they can definitely be multiple. They can definitely be large. I would put pilometricomas also in the differential. Other neoplastic condition which you should be aware of for this age and for this patient, you should think of xanthogranulomas as well. Juvenile xanthogranulomas could definitely be in the differential diagnosis. So for this patient, the main investigation you would do is do a biopsy for this patient, and when you did a biopsy, you would see this picture. So regardless of what stain we use, this is very obvious that there's a lot of wet in the dermis. So this is either a colloidal iron or Alcian blue. So this is mucin, correct. So given the age of the patient and the way it's presenting, let's go back to our patient. So given the way it presents, so now you know there's a lot of mucin, okay? And when you talk about conditions that give you mucin, it could be either mucinosis, it could be secondary to a primary derm disorder, or it could be usually part of connective tissue disease. So given the age of the patient and given the way it's presenting, like if I think of mucinosis, this does not look like sclerodema, for example, because in children's sclerodema, when it occurs usually after streptococcal or any upper respiratory tract infection, usually causes tightening of the face and neck, or in diabetic patients, and can cause tightening of the skin on the back and the back of the neck. This does not look like scleromyxedema, which usually presents with more like papules and sclerodermatous tightening rather than large nodules. This does not look very much like one of the connective tissue diseases, unless it's like papulonodular myxinosis of gold, which usually occurs in the trunk and in older patients. So the most likely diagnosis here would be self-healing cutaneous mucinosis, which Dr. Mishal said earlier, and the correct answer. But keep in mind that this diagnosis, you usually only make it retrospectively when the lesions heal, because the other differential diagnosis for this would be focal cutaneous mucinosis, which could also present the same way and be persistent. Let's go to the next case. Okay, this is a little more exciting with a lot of differential diagnosis. Can anyone come up either with the audio or with typing, whichever? So what we see here is plaque or multiple plaques in the distal upper extremity. We can see it looks like a keratotic plaque. So MK. Psoriasis, that would be definitely my number one differential diagnosis, given how psoriasis is common. Lupus vulgaris is also a good differential diagnosis, given how so Dr. BZ, you can see how lupoid, the area that is not keratotic, like sclerotic, scarred. So definitely lupus vulgaris would be in the differential diagnosis. But when you're talking about lupus vulgaris, you're talking about a type of TB. There's another type of TB that could look like this, and it actually would be more likely than lupus vulgaris. Can you tell me which type I'm looking for? Which type of cutaneous TB? Exactly, Dr. Mashal. TB verrucosus cutis, which is a form of primary inoculation TB, that would be more of a fit for this, but I wouldn't say lupus vulgaris is completely wrong. It all depends on the patient's immunity and the way lesions spread to this area. If it was a direct inoculation, it would be TB verrucosus. It would be, if it was like hematogenous spread, I would say more likely to be lupus vulgaris. Okay, anything else on the differential? Let's say this was one of the fungal infections that was inoculated in this area. And when I did a biopsy, I saw some medlar bodies. Chromoblastomycosis is a good differential, is what I'm looking for. It's not the diagnosis, but it's a good differential diagnosis. What else? Let's think of things that are not infectious. So we've been talking about, like, other than psoriasis, we've been talking mainly about infections. So let's talk about stuff that are not infections. Let's say this lesion was very itchy.
LSC?
LSC, I mean, I wouldn't say completely no, but something more likely to be more likely than LSC, and like, hypertrophic like this with this keratotic scale.
I would think about lichen planus, even though
Lichen planus, so the hypertrophic lichen planus could look like this. So again, let's see how the biopsy can help us with this patient. What do you see with the biopsy? Before you come up with a diagnosis, what features do you see?
I see like follicular plugging.
There is follicular plugging, I'll give you that. There is a lichenoid infiltrate, that is correct. But follicular plugging is very striking here. And the infiltrate, is it just below the epidermis, or is it going deep and involving the hair follicles as well?
It is going deep.
It's going deep. So lichen planus is not going to give us this picture. Okay, lichen planus usually would be just a pure lichenoid infiltrate hugging the epidermis, and that's that. And yes, Dr. Mariam Najm, it is a lymphocytic, mostly lymphocytic, a little bit histiocytic infiltrate, mostly lymphocytic infiltrate. So there's follicular plugging, there's atrophy of the epidermis, if you can see here. I don't know if you can see my cursor or not. There's perifollicular infiltrate, superficial and deep infiltrate. Given this the picture we saw, what would the diagnosis be?
DLE?
Discoid lupus erythematosus. So Dr. Beasley, it's not lupus vulgaris is a type of TB. This would be discoid lupus, DLE. Good answer. So how would you treat this patient? The previous patient, we said that is reassuring because it's self-healing. But how would you treat this patient?
You can do Plaquenil, or you can also do intralesional, a combination of both.
Okay, great. All of you and Mishal, correct. You can do antimalarial, you can do interlesion steroid, but the first thing is first. You tell them to avoid the sun, and yes, my first line treatment would be either interlesion or or super potent topical steroids with antimalarials. Correct. Next is, so this patient, very nice differential diagnosis we can see for this patient. Remember, the more active you are, the more you quickly answer, with the more cases we'll cover, and the more you will learn. So Xanthelasma would be definitely my differential diagnosis from 1 to 3. This is more likely. NXG, very good, Amy Wine. Canal, sarcoidosis, that is a very good differential diagnosis from canal. So we got Xanthelasma, we got NXG, we got sarcoid. That would be my main diagnosis. Amyloidosis, very good, very good. I like amyloidosis. It's a common location, and it definitely can look like this amyloidosis. So yeah, that's very good differential diagnosis. So again, with this patient, mostly I will do a biopsy because the entities you mentioned, they can all be differentiated by histology. So let's go and look what we see here. So this is quite a classic picture of one of the differentials that you guys mentioned. So can anyone tell me what this is? Sarcoidosis, perfect, Mishad. So just remember, sarcoidosis, like lupus, like syphilis, can be a great imitator. It could take many forms. Sarcoidosis can look like ichthyosis, could look like lupus. Sarcoidosis can look like hypertrophic scars, especially when it develops in areas of scarring. Can look like psoriasis, can look like lichen planus. So again, look back to this picture. You can sense that when and retrospectively, when you know the diagnosis and you look like especially the medial canthal area here, you can see that it does have this orangey granulomatous appearance. So in retrospect, it does make sense as one of the granulomatous disorders, less likely to be like amyloidosis and NXG. So yeah, sarcoidosis for this patient. Treatment for this patient, it depends on the systemic involvement or not. But can you tell me the treatment options you would offer for your sarcoidosis patient, other than topical steroids? No one answered? No one wants to answer? So you got your antimalarials for the milder cases. You got your for more severe cases, you can give the systemic steroids. You can give anti-TNF treatment. So yeah, those would be good treatment options. And then you got like other more aggressive treatment options like mycophenolate and methotrexate. But usually my preferred would be like, for the milder cases, topical or intralesional steroids with antimalarials. And then the more severe cases, you can give steroids and anti-TNF agents. So one of the themed areas now. So we'll talk about some palmoplantar keratosis. So you don't want these guys slapping you because they have a very hard palm. Okay, so diagnosis, straightforward diagnosis. If you got like striate PPK and woolly hair, what would your diagnosis be? This should be like quick cases. Just to refresh your memory on PPKs. Nexus usually has a more diffuse PPK, like and with the cardiomyopathy. Carvajal, correct. So Carvajal has and Nexus are very similar, and you know, each of them are caused by genetic abnormality, if I'm not mistaken, autosomal recessive, placoglobin and desmoplakin. The both of them can cause a cardiomyopathy. Both of them can cause woolly hair, but Carvajal usually causes a striate PPK, and Nexus usually causes a diffuse PPK. Just remember this for your board exam. So again, I should have not answered and given detail, but like, you know, when you see this, this is Nexus. So diffuse PPK and woolly hair. Okay, this patient, what you can see here is some psoriasiform lesions on the knee, PPK, but there's a specific feature in this PPK. Can anyone point it out to me?
Discern.
The what? A transgredient PPK, yes. So a transgredient PPK is one that does not limit itself to the palms. It goes and crosses all the way to the dorsum of the hand, as you can see this patient showing you. So we have several transgredient PPKs. Two of them are autosomal recessive. One of them has teeth or nail abnormality, and one doesn't. So which type is this? Maldemelida, perfect, Mariam. Perfect, Maldemelida PPK. Next is, this is a PPK that has cobblestone papules in the dorsum of the foot, and this histological feature, whoever could tell me this histological picture is my star resident. So yeah, this is Clouston syndrome. Perfect, Michelle. So this is Clouston syndrome, and this is syringofibromatosis, acrosyringofibromatosis. So you can see here the reticulated growths of the epidermis into the dermis, and you can see here it's all like, you know, syringomatous with the sweat aspect, sweat gland aspect, and definitely it has PPKs. Perfect. Next is this patient. Focal PPKs. They tend to be painful. Sometimes you can be hyperhidrotic, like the image D you can see here. Thickened nails, and something in the axilla. Whoever would tell me that would be smart. Image F. Exactly. Pachyonychia congenita type 2. Correct, Mishal. And the lesions of the axilla? I can't hear you. Steatocystomas. So steatocystomas are common in Pachyonychia congenita, especially type 2. This patient, this is an interesting one. A little late this time, Michelle. So, what do we have here? So we have somewhat of a reticulated PPK in the dorsal, reticulated keratosis in the dorsal foot, and what we call it pseudoinum, loss of the digit, and honeycomb-like PPK in the palms, and perfect, Amy Wang. This is Bohwinkle type. Perfect. Next is, so this patient has a PPK and has these lesions, and this is like a bird book diagnosis. By bird book, I mean, like, you know, this is like a bird. When you see it, you know this with the type. It's straightforward from the way it looks. Erythrokeratoderma variabilis, perfect. So good, Mariam and Michal. Erythrokeratoderma variabilis usually has a fixed plaque and transient erythematous patches, as you can see on the left side here. And a considerable amount of these patients would have PPK as well. Okay, next, older patient. I'm not a radiologist, my wife is, but I don't need to be a radiologist to see that there's something really wrong in this patient's lung. I hope that this is the lung, actually. No, it is the lung. Anyone? So try palms. So yeah, so this is PPK related to malignancy. When sometimes palmoplantar keratoderma could be the result of a malignancy. Sometimes you can call them tripalms, and in certain situations you can call them Basic's syndrome. But Basic's usually if you have like lesions also under your ear and usually more psoriasiform. Pure PPK in the palms can be very commonly associated with the lung cancer. So if the patient, when you have a young patient who has PPK, you should know that this is more likely to be genetic. But when an older person suddenly develops PPK, you should think of other entities like thyroid disorders. You can think of keratoderma climactericum, for example, on the soles of the foot. And when you see the patient looking like emaciated, having other symptoms, you should think of malignancies, particularly lymphomas and pulmonary malignancy. Okay, let's go back and do some CPCs again, clinical pathological correlations. This patient, sudden onset, multiple lesions. Come on, differential diagnosis, very quick. Sweet syndrome, perfect. That would be my first differential diagnosis. What else? Look at the center of the lesions. There's something in the center of each lesion. Erythema multiforme, very good. Let's say the patient tells you that each of these lesions. Oh, Rowell syndrome, yes. So EM in the context of lupus. Let's say this patient told you that they take medications, and every time they took medications, they got a new lesion, and some of them pop up, and the previous ones come back in the same location.
Fixed drug.
Fixed drug eruption, exactly. And if it's not pigmenting, you would think of which drug, if this was fixed drug.
Pseudoephedrine, I think.
Pseudoephedrine and phenolphthalein, I think. Which one of them? I think. So yeah, so this would be a good differential diagnosis. And then when you look at the histology picture, what do you see here? You see there's a lot of death in the epidermis, interface dermatitis with a lot of dying keratinocytes. There is no neutrophilic infiltrate, which would rule out sweet syndrome. There is no pigment incontinence in the dermis, which would rule out fixed drug eruption. So we are left with what? As a diagnosis with erythema multiforme. Perfect. So erythema, depending on the context of the patient, if this was a lupus patient, I would think of Rowell syndrome. If this was not a lupus patient, I would think of typical erythema multiforme. I put this picture for you to be aware that erythema multiforme. Okay, we know it as an acral disorder, but sometimes when it gets more severe, it can definitely become a little more generalized, making the distinction between it and SJS a little bit difficult in some situations. Okay, moving on. This patient, young woman, develops these lesions all over the extremity, all over the trunk. I don't know if I have another photo. Okay, I don't have another photo. Misha, is a very good differential diagnosis. What else? I didn't hear what the person said on audio.
I did some workout, and then I ate breakfast. Such an early bird.
I can't hear.
I was throwing guttate psoriasis, even though I don't really see a lot of scales.
No, guttate psoriasis could definitely be in the differential diagnosis. I mean, common things are common, so guttate psoriasis would be in the differential.
Oh, that's why I wake up early. It feels better to wake up early.
Okay.
Not like 6 a.m. early, but like.
So keep your audio closed, please, if you're not answering. So yeah, pityriasis rosea definitely in the differential diagnosis. So we got pleva, we got pityriasis rosea, we got guttate psoriasis. There's another heavyweight that you guys missed. I mean, chickenpox, okay, I wouldn't say no, but something more that would look more like this and would go more with the age of the patient.
If they went to the beach or
no, I wouldn't think of that. Think of something that you would need a blood test to confirm. Syphilis, exactly, secondary syphilis. That's very good differential diagnosis, and definitely LYP. If you think of pleva, you should think of LYP. Okay. So yeah, I would do so for investigation for this patient. First thing I would do is a VDRL, and definitely I would do a biopsy for this patient. And when you do a biopsy, let's see. This is the features you can see in the biopsy. This is quite distinctive of one of the conditions. What do you see here? Let's see, do I have another image? No. So this is the only one. There's a wedge-shaped infiltrate, perivascular, intense perivascular. There's neutrophils in the stratum corneum, which very few conditions can give you that. There is a good interface dermatitis. So, and there's the necrotic keratinocytes. So what would your diagnosis be here? Oops, sorry. Anyone?
Is this pleva?
So, someone said pleva, someone said syphilis. It could, and PLC. Well, pleva and PLC are a spectrum, but if I would go on histology alone, this would be more of a pleva picture, given the more intense infiltrate and more deep. I would say syphilis can definitely give me this kind of picture, but the lack of plasma cells here and the wedge-shaped infiltrate would make me head more towards pleva. So this is definitely a case of pleva, but again, if I saw this picture, even histology picture, I would definitely order a VDRL to make me completely rule out syphilis. Next case is this patient. Multiple skin-colored papules suddenly developed on the face of the patient. Okay, I'll give you a hint. This patient used to have long-term acne treatment with the oral antibiotics, for example. Osteoma cutis, perfect, Fatma Khamdan. Osteoma cutis. So let's see with the histology. Does it confirm it? It does confirm it. You can see it's not calcium, it's bone here. So osteoma cutis. This patient, this is also a bird work diagnosis. You can see it. I remember I saw this patient once, and I would never forget how this patient looks like. I mean, not this particular patient, but like this condition. Congenital erythropoietic porphyria, exactly. So there's a type of porphyria, usually which enzyme is deficient in this type of porphyria. Exactly, that's good, Michal. You're porphyrinogen synthase, co-synthase. And they would have elevated uroporphyrins and coproporphyrins in the urine and in the stool. This could be definitely one of the worst types of porphyria, along with variegate porphyria. They can have mental retardation in few cases, but mostly the issue is with the skin. They can definitely never go in the sun. Severe scarring. They can get severe hemolysis requiring multiple transfusions. It's definitely one of the worst types of porphyria. Next is this is a nice. Is this the same as Gunther's? One of them you asked. Yes, this is the other name for congenital erythropoietic porphyria is Gunther's disease. So yeah, Amy one. Good question. So next, this is a nice patient with a good differential diagnosis. Can you tell me what you think this is?
Digital myxoid cyst.
Digital myxoid cyst would be the top of my differential diagnosis, correct? Before, definitely I palpate it. So myxoid cyst would be in the differential. Anything else? Gout, definitely. I like you the differential diagnosis as gout. Good. So myxoid cyst versus gout mainly for this patient. Anything else would be less likely. I would add calcinosis cutis also in the differential. Glomus tumor, I wouldn't say no to that. Usually they can occur in the under the nail and in the palm, but they can definitely be located in this location. Usually they're more bluish rather than more whitish when they develop glomus tumors. But based on the location, I wouldn't dismiss that differential diagnosis. So we got gout, calcinosis cutis, myxoid cyst, and glomus. So let's do a biopsy and see how it looked like. So when you see this Is feathery deposition because we didn't fix this in alcohol. We fixed this in formalin, so you wouldn't see the brown color. You see the feathery deposition and some foreign body giant cells around it. So this is a case of gout. Perfect. This patient, tiny lesions, multiple.
Lymphangioma.
Lymphangioma is a very good differential diagnosis. Perfect. What would you add in the differential as well? I would add angioma, angiokeratoma, very good. I wouldn't say angioma serpiginosum because in angioma serpiginosum, usually the lesions are more linear and usually they are less thrombosed than angiokeratoma, but I like angiokeratoma. So angiokeratoma versus lymphangioma circumscriptum for me in this case. And when you do a biopsy, again, the biopsy is a little bit difficult here. You can see features of hyperkeratosis, but then these vessels are mostly lymphatic vessels. And when you see blood, that doesn't immediately mean that this is venous or arterial. It could be like, bleeding into the lymphatics, which is the case here. So this is a case of lymphangioma circumscriptum. Next. Can anyone tell me what this is? Granular parakeratosis is a good differential diagnosis, sorry. Granular parakeratosis is a very good differential diagnosis for this. What else? DLE, I mean, it could be DLE, but it's not like usual. It's not, I wouldn't say no, because it's not like really scarring, and the keratosis is different from that of a DLE. Pemphigus vegetans is I like the pemphigus vegetans. That's a very good differential diagnosis. Oh, you said Haley. Sorry, I didn't hear you. So Haley, definitely Haley is in my differential. That would be my top differential diagnosis when I see this patient. I would think more of Haley than the other things. The inferior component makes me think maybe of a granular parakeratosis, but granular parakeratosis doesn't give me this erythematous diffuse, moth-eaten or pattern. But I would consider it. So granular parakeratosis, we got pemphigus vegetans, we got Haley. Anything else before we go on and see the biopsy?
Also in inverse psoriasis.
Inverse psoriasis, yes. Why not? Given that it's erythematous in the center and more, let's say, keratotic in the borders, definitely that could be. Extramammary paget, I mean, I wouldn't say entirely no to that, but usually we know the locations of extramammary paget, so I wouldn't entirely dismiss it, but it will be much less likely than the other differentials we mentioned. So let's go here. What do you see on the histology? So Michel says Haley disease. So there is some acantholysis, but is the acantholysis that, look, especially in the left image, is it that extensive, involving all the layers of the epidermis? No. And the pointer is pointing at something. There's corons and there are some grains here. So if it's a suprabasal acantholysis and many corons and grains, what would be the more likely histological picture here? Derriere, exactly, Dr. AJ, Aisha, Musa, I assume. So this would be a histological picture of Derriere. So when we go back to this patient here, could this the clinical picture fit with Derriere or not? Yes, Bishal. Yes. So this could be an inverse Derriere. So yes. So this is a case of inverse Derriere disease. Can look clinically and histologically quite similar to Haley disease, but there's a subtle differences. I would say this part, the inferior part, the verruciform keratotic part would be a hint clinically towards Derriere, just like the corons and grains were a hint towards Derriere on histology. Next is this patient. Multiple annular lesions all over the trunk. Lepromatous leprosy or borderline leprosy. I like that. Both of you are correct because we did not examine the patient completely. We don't know how symmetric the lesions are or the immunity of the patient. So, or what we see on histology, very, most importantly. So it could be lepromatous leprosy. It could be um, uh, borderline leprosy. But if it was borderline, I would think more towards borderline lepromatous rather than borderline tuberculoid. Sarcoidosis, Sean, very good. I mean, I've seen sarcoidosis patients who present this way, so definitely yes. Let's say the patient went camping recently and then they had an initial lesion that disappeared and then got these lesions later on. What do you think of something, especially during this season? Here in New York, of course, not in GCC. There's no camping in GCC, this area. It's extremely hot. So
Diffuse Lyme disease?
diffuse secondary Lyme disease. I mean, this is less likely to be that, but you should keep it in mind, especially during this time of year. So Lyme disease definitely in the differential diagnosis. Yeah, I mean, I would also add disseminated granuloma annulare, which usually can be papillary or annular, but that definitely would put that differential diagnosis. And the histology here is very, very, very distinctive. So what would the diagnosis be, especially on the right-hand side? Let's say we use the Phyte stain here. So yes, borderline lepromatous would be more correct. Either borderline or borderline lepromatous. I wouldn't call this a completely lepromatous because you can see here there's no Gren zone. So usually when with tuberculous you get more like close to the epidermis, and then if you go more towards the lepromatous end of the spectrum, there is no there is a more and more obvious Gren zone. So yeah, this would be a borderline leprosy patient. So perfect. Next is here.
Dermoid cyst.
Dermoid cyst is a good differential diagnosis, and when you say dermoid cyst, any other cyst can be a possibility, like epidermoid cyst, for example, is in the differential diagnosis. So not much differential here. What investigations would you do for this patient? Very importantly.
Imaging.
What kind of imaging? Anyone can tell me what investigations would you do for this patient? Okay, someone said ultrasound. So this is actually a trick question. For this patient, I would only do a biopsy or an excision. I would not need to do any imaging. Why would you do imaging for this patient? So when a patient has like a dermoid cyst, you would want to worry about intracranial extension of the lesion, which I assume why you want to do the imaging. But the dermoid cyst can occur either in the lateral, most likely in the lateral canthal area, or in the nasal root area. It has been shown that the lesions of the nasal root are the ones that could be communicating with the CNS or with the deeper structures. The ones that are in the lateral canthus are not associated with that. So you generally don't need to do any investigations for those. So yeah, so just to show you the histology here, the dermoid cyst would differentiate between epidermoid cyst. See, it keratinizes normally just like an epidermoid cyst with a granular layer, as you can see here. But in addition to that, there are adnexal structures in a dermoid cyst. So in this case, you can see the complete pilosebaceous unit in the wall of the cyst. This one. Just since we're talking about cysts or lesions in childhood, what would you call this? Accessory tragus. Okay, perfect. Which can develop in multiple locations, as you can see in this image. It can occur even in the neck. So next here, this patient, cute little baby. Differential diagnosis. For me, this is pretty much straightforward for one entity, but I would definitely also biopsy this patient, but what would your differential diagnosis be here? Maybe one or two entities I would think for this patient, but what would you think? Diffuse mastocytosis, Amy1, perfect. Very good differential diagnosis. That would be my differential diagnosis when I see this patient. Anything else? I mean, again, like seeing this clinical picture is it's very hard to think of something else. I mean, LCH, maybe if it was just the papular component, but this diffuse component would definitely not go with the LCH. Again, if it was nodular, yes, but this diffuse skin thickening, no. And again, if it was only the diffuse thickening, I could think of some of the types of the ichthyosis, but the ichthyosis is not going to give me these nodules. This is pretty much straightforward, but again, you always need to biopsy to make sure for these patients, and you can see here there's a lot of mast cells with the fried egg appearance, very distinctive for a mastocytosis. And then when you stain it with immunohistochemistry, it gives you a good picture. So moving on to conditions which you can get at work. So work-related dermatoses. This is one of our quick we want very quick answers for this one. We don't want to spend a lot of time. So what would this be?
Meeting.
So guys, if you're not answering, please keep your audio closed. Tell me what is this? What kind of work-related dermatosis is this? Come on, guys, this is easy. You answered harder questions earlier. Wheals. So this could be wheals related to work. So this can occur very commonly in healthcare workers who use latex gloves, or occur in those who handle some vegetables that can release histamine from the mast cells. So yeah, this is work-related or contact urticaria, we would say. Yes. So next is this. What would this be?
Fissure.
ORF. That's a very good difference. That's the diagnosis of this. ORF. It's work-related. It usually occurs in slaughterhouse workers or farmers. So yes, ORF. And this. Notice the purplish color. Some areas are purpuric. Involvement of the distal upper extremity. Erysipeloid, perfect, which is an infection caused by what?
Erysipelotrix.
Erysiopathia, that is perfect. So good. Moving on. Here.
Is this like comedones?
Comedones, yes. So this is Chlor Acne, which can occur in those who deal with a lot of hydrocarbons at work or cutting oils. So Chlor Acne, perfect. This patient complains. Think of the commoner stuff now. A lot of itching in the hands. Yeah, that's correct. Irritant contact dermatitis. Always think of the common things when you get to work. This accounts for at least 80 or 90% of work-related derm complaints. Next. So we can see a flagella dermatitis. There's at least 4 or 5 entities that I would say can cause a flagella dermatitis, but only one of them is work-related. So bleomycin is correct as a flagella dermatitis, but whose job is it to take bleomycin injections? Well, it's the patient's job, but it's not a job. So yes, good again, Sean. That's a shiitake mushroom dermatitis. Perfect. That's a very good answer, all of you. Okay. So next is again another work-related dermatosis. Vibrational, good, especially those who use pneumatic pumps or those who do the vibratory things where you dig the ground with them. Very often you can get vibration, hypopigmentation, and Raynaud's phenomenon in your hand. So this is that was the last image of work-related dermatosis. Now some more clinical pathological correlation. What would your differential diagnosis for this be?
Kaposi sarcoma.
Kaposi sarcoma would definitely be. I would definitely be alarmed regarding Kaposi sarcoma for this image. What else? Pseudocapulsi sarcoma, perfect. Angiosarcoma. Angiosarcoma would be less likely given the location, but I mean, you can never rule out complete angiosarcoma. Angiosarcoma usually occurs in the head and neck, but yeah, why not? But to me, Kaposi and Pseudocapulsi sarcoma, which is acroangiodermatitis, will be more likely of a differential diagnosis. So let's see what the histology tells us. So what does the histology tell us here? So we have a lot of blood vessels. There is no significant atypia in the vessels. There is no much cliff-like shape of the blood vessels. There is some spongiosis. So this is a case of pseudocapulsi sarcoma. Pseudocapulsi sarcoma is just severe stasis dermatitis that gives me the clinical picture of Kaposi sarcoma, but not the histological picture. So this is pseudocapulsi sarcoma, which is called acroangiodermatitis. Okay, acroangiodermatitis. Next. This is not clinical pathological. This is straightforward child with severe oral thrush and this infection and this. Anyone? Diffuse candidiasis. There's another. There's a better way to describe this condition. It's not diffuse candidiasis. I mean, it is diffuse. I mean, there's candida, but I wouldn't call it diffuse. This is not a candida, and the B is not a candida infection, for example. CMC, that is the more correct answer. So CMC, chronic mucocutaneous candidiasis. So I actually was under the impression that chronic mucocutaneous candidiasis always causes candidal infection, like image A and image C, which is also candidal folliculitis. Until I saw my first CMC patient who had a severe dermatophyte infection, and then at that point I realized that it's not just candida; they can get also tinea infections very commonly. So I put this image for you to realize that as well. So this is a case of chronic mucocutaneous candidiasis. A little clinical pathological correlation here as well. Intense or thick hyperkeratotic verrucous plaques. You can see here multiple in the shins here and the posterior leg here. Chromomycosis would be my good Fatma Khamdan. This definitely would be my first differential diagnosis, chromoblastomycosis. But usually chromoblastomycosis involves, especially when it's like verrucous and hyperkeratotic, it usually involves one location, not multiple. Rupoid syphilis. Wow, someone just read a journal or went to a conference. So that's what I. So yes, Rupoid syphilis definitely would be in my differential diagnosis, and this is actually what this was. So when you go to the histology, you can see when you have an intense. Sorry, let's go back. When you have an intense lichenoid infiltrate where you can't even see the rete ridges and a lot of plasma cells, this is syphilis until proven otherwise. So this is a case of tertiary syphilis that is, we describe it as rupoid because it's like thick and keratotic. So yeah, remember, if there's anything the lesson of this lecture, remember the great imitators: sarcoidosis, syphilis, lupus. They can look like anything, and always try to rule them out in anything that looks odd. And you can see here the spirochetes are very obvious. This patient is immunocompromised. What would your differential diagnosis be? Bacillar angiomatosis. Very good, Amy Wan. That's a good differential diagnosis. What else would you think of if this, let's say this patient is immunocompromised and has these shiny papules all over the body? I would think of things like histo. Very good. So yeah, his girl is fine. Very good. So the differential, this girl is fine is a differential for something, but so molluscum contagiosum is a differential diagnosis, especially when you got like in an HIV patient. So yes, when you get a lot of molluscum contagiosum like lesions, you should think of things like disseminated fungal infections or HIV. When we go to the histology, we see mostly a vascular lesion with, if you can see here in image 2B, there's some of the organisms, which we can see them here, the Rocalinae or the Bartonellas, now we call them. So this is like Amy Huang said earlier, bacillary angiomatosis. So yeah, okay, next case. Very good, Amy Wang, by the way. Very good, Mariam and Najim. Answering a lot of good questions, and Mishal. And Ruth as well. So next, this image. Keratotic lesion in the extremity. We saw one earlier of keratotic lesion in the extremity, but here it's a younger patient. What would your differential diagnosis be? This is a very exciting case, to be honest. Leishmaniasis, I like that. Very good leishmaniasis, and Mariam and Najim. So very good. But what else? Candida, I mean, in the context of a chronic mucocutaneous candidiasis, yes, but in a regular patient, Candida would not cause this kind of granulomatous response. I mean, yeah, unless the patient had one of the immunodeficiency syndromes, usually they wouldn't develop this kind of granulomatous response to a Candida. So yes, it does appear verrucous. So what would your differential be? I mean, I mean, yes, a little bit verrucous, but I would say more hyperkeratotic rather than verrucous here. So what would your differential be? Nothing other than candidiasis and leishmaniasis? You guys started well. Psoriasis, definitely psoriasis. Why not psoriasis? I mean, when I see a patient like this, you think of the common thing. So again, I mean, given how this lecture has been focusing on unusual entities, you know that it's not going to end up being psoriasis. But if I saw a patient in the clinic and one of my residents said psoriasis, that would be the correct answer, because you always think of the common thing first. So definitely psoriasis. I want to hear these answers. I want you to tell me psoriasis. I want you to tell me like hypertrophic lichen planus. I wouldn't even mind if you told me like a severe wart, for example, or LSC. Very good, Sean. So think of the common entities first. So these are things you should keep them in mind first. The unusual entities, you diagnose them when you're surprised by the histology or when the patient doesn't respond to the initial treatment of a more common condition. So let's go see the histology now. So this is not a feature of leishmaniasis or psoriasis or candidiasis. What we see here is a lot of lymphocytes. Let's go deeper here. The CD4 shows us how they're going way up in the epidermis in a very passive epidermis, not much spongiosis in the epidermis. I mean, there is a little bit, but not much. There's a lot of halo around the lymphocytes, which look a little odd, especially here. You can see you have large lymphocytes, which is not a common thing to see in exostosis. So what would your differential diagnosis be here? MF, very good. So what kind of MF? Pagetoid reticulosis, perfect. So pagetoid reticulosis type of MF is the diagnosis. Very good, Dr. Fatma Khamdan. So yeah, again, when you look at here, pagetoid reticulosis is, like, let's say, the best kind of MF you can get. Usually it involves one location of the body. Very epidermotropic it tends to be. And it can involve younger patients, unlike MF, typical MF, which usually favors the older population, other than hypopigmented MF. So moving on, this is a spot diagnosis. Melia and plaque, perfect, Sean, and you can see it here in the image. Next, this patient has these lesions. PRP, well, very good differential diagnosis, PRP, but what else? Figure 8 erythema differential diagnosis. So I mean, yeah, there's a lot of differential diagnosis for figure 8 erythema. Let's see, like, you know.
واليوريا كرياتين normal. في few more tests ما طلعوا وقالت بتروح تقول لهم انه يطلعونها بسرعه. Oh, good
So
luck.
again, keep the microphones mute if you're not answering questions. So what figure erythema differentials would you suggest for this patient? Granuloma annuli, the differential diagnosis, erythema marginatum, or let's say secondary Lyme disease would be in the differential diagnosis. Anything else? Tinea corpus, definitely. I've seen a lot of patients who had this picture and turned out to be tinea corpus. Actually, if I saw this, my first diagnosis would be tinea corpus for this patient, especially the crusty borders here would go more with tinea corpus than the other entities described, like secondary Lyme disease or especially granuloma annulare. This crusted border is a big hint towards something that is involving the epidermis, not just the dermis. So tinea corpus would be in my differential diagnosis. Let's go see the histology for this patient. So you see this. Does this change your histology? Change your differential diagnosis? Sweet to know. I mean, I see you saw the neutrophils, so yes. Why you think of sweet? Yes, but sweets usually has a much more intense neutrophilic infiltrate. It can present with a subepidermal blistering, but it usually would be bullous, not like the picture we saw earlier. It wasn't really bullous. Nutritional deficiency, I don't see much pallor in the epidermis, and what I see is a subepidermal blister with neutrophils here. So I wouldn't say, so it's subepidermal. So linear IgA bullous dermatosis would be in my definitely differential diagnosis, but again, look, so there's two types of dermatology you need to know. There's exam dermatology and there's real life dermatology. If this was an exam, yes, I would want you to say linear IgA bullous dermatosis or lupus, for example, like let's say bullous lupus. But in real life dermatology, when you see a subepidermal blister with eosinophils, you would think of bullous pemphigoid. With neutrophils, you would think of bullous pemphigoid. With sparse infiltrate, you would think of bullous pemphigoid. Bullous pemphigoid is by far much more common than linear IgA bullous dermatosis, much more common than EBA, much more common than lupus, bullous lupus. So always think of bullous pemphigoid, even if it's a neutrophilic infiltrate. And dermpath dermatopathology, what usually would make us diagnose linear IgA bullous dermatosis is not seeing a subepidermal blister with neutrophil. What would make us do the diagnosis if it was a linear IgA on immunofluorescence. So this is a case of linear IgA bullous dermatosis, yes, but the diagnosis comes not from the clinical or from the HNE. Well, a little bit from the clinical and a little bit from the HNE, but mainly from the DIF findings. So this is a case of linear IgA bullous dermatosis, and if you can see again the clinical here, it does have an annular picture and it has a crusty border, which would hint to you that this is a blister. So remember, just like bullous pemphigoid, the initial lesions might not be like frankly bullous. They could be erythematous, eczematous, and then start to develop blisters later on in the disease. So we'll do one more case, or we did this before, something similar. So this is lichen sclerosis, as you can see here. One more case, and that's it. That's our last case for today. A very exciting case. Can anyone tell me the differential diagnosis for this? Erythema gyratum repens, very good. Yeah, so yeah, this is our last case. Tinea imbricatum, very good. That's a good differential diagnosis. You remember what I showed the last time in the Kodachromes? I tricked you. I showed you a gyroterythema, turned out to be tinea imbricatum. So our differential is EGR and tinea imbricatum. And let's see the histology here for our last case. Sorry, no, not that. I just scrolled up by mistake. So let's see here. I can see an acanthotic epidermis and something going on in the stratum corneum. So there's some areas of perikeratosis, some areas without perikeratosis. I would call it a checkerboard perikeratosis. Let's say we did PAS staining and there was no tinea here. this would be a diagnosis of PRP. So I just put this image for you to be aware that when you get PRP, the resolving phase of a PRP can look very much like erythema gyratorum repens. Erythema gyratorum repens is exciting exam for exacting entity when it comes to like board exams. But in real life, you always have to think of the things that are more common. Think of tinea imbricata. Think of resolving PRP, especially in a younger patient who doesn't have signs of malignancy. The peeling scale definitely hints to you that this is more of an epidermal process or something going on with the epidermis. So you think more towards the tinea or PRP. So this is, yes, this is a case of resolving PRP. Very good, all of you. Thank you for joining us. And now we will move on to an exciting session of quiz answers. And this time we were happy to know that there were much more people who answered the quiz. So on to you, Dr. Alva, for the quiz. Dr. Alva, are you there?
Yes, thank you so much, Dr. Amin, for a variety of interesting cases. I'll just fix my computer just for a while.
فاطمة شوفي مين يمكن هدول أصحاب لولو.
Can you just make sure to mute your microphone, please? Can you see my screen?
Yes, we can see it.
Okay, perfect. Just 1 second. I'll put the chat box at the side as well. Okay, so let's start. Hope you are still awake and active for my session as you are with Dr. Amin's session. Just before I start, just apologize for 2 questions that I haven't marked the correct answer, so it appears as 0. No worries, I add your marks up. And most of you have a really good mark actually. So congratulations for our highest score, Dr. Mishal Al-Hamadi. I guess he is from Saudi Arabia. So well done, Dr. Mishal. And up we go. So see, the first question is a 29 years old, a 16 weeks pregnant female, present with your clinic with psoriasis affecting more than 12% of her body surface area. She wants to discuss availability treatment option for her as she feels miserable, and she states that her psoriasis is adversely affecting her quality of life. Which one of these drugs is a preferred agent to treat moderate to severe psoriasis during a pregnancy? You can type your answer, you can just shout the answer. Okay, infliximab, acitretin, methotrexate, citralizumab, or topical steroid? This is an easy question. Okay, D, yes. And as you know that Cimzia is a TNF-alpha inhibitor, and hence it have a very minimum transplacental transfer, so it is safe to use it during a pregnancy. And the dose usually is 400 milligrams subcutaneous injection. You start at week 0, 2, 4, and then every other week. Okay. Second question, a 53 years old Brazilian man present with a 1-week history of a painful erythematous papule and plaque on his face and the trunk, along with a bilateral upper extremity edema. He first noticed the lesion 2 years ago, but they have recently worsened. He denies fever, weight loss, and joint pain. A review of the symptom, he has a positive only for a mild numbness and muscle weakness of his hand. What is your most probable diagnosis? Type 1 reaction, type 2 reaction, leucophenomena, Dermoid leprosy, Histoid leprosy. Well done. Yes, it's type A reaction. So type A usually they're characterized by an acute to subacute inflammation of the skin and nerve, and they manifest with both new and pre-existing lesion and associated with edema of the upper extremity and nerve involvement with anomalous. Unless type 2, they present with the systemic symptoms, and the biopsy will usually help to differentiate the both. The leukophenomena is a rare thromboembolic reaction. They present with a very painful erythematous violaceous lesion, and eventually they ulcerate, and they have a systemic symptom as well with fever, anemia, and epistaxis. The Dermoid leprosy, they present with a diffuse, systemic, and non-anesthetic lesion, and may progress to copper-colored macule, papule, nodule, and they usually present with a thickened skin, and you'll see the lean-on faces and the loss of the eyebrow, which is mostly characteristic for most of the lesion, most of the patient. Histoid leprosy, where they're very soft skin-colored subcutaneous papule and nodule. They often located in the bony surface of the upper and lower extremity and buttock, and they're commonly seen in Floroid leprosy and borderline leprosy. Okay, third question. All of the following are characteristic of Behçet syndrome except optic neuritis, uveitis, oral ulcer, urethritis, genital ulcer. And I think most of this question, most of you get it right actually, but haven't put the correct answer for it. Yes, yes, indeed, urethritis. So you know the classical symptoms of Behçet syndrome, the criteria for diagnosing Behçet, it's very important. And this has been agreed from the international study of Behçet syndrome since 1990. The patient usually present with a recurrent oral ulceration and +2 of the following: recurrent genital ulceration or the eye lesion with the posterior uveitis and the optic neuritis and the retinal hemorrhage, the skin lesion with the erythema nodosum-like, and they have to have a positive pathology test. So recurrent oral ulceration +2 of any of these, okay? And this is, you will find it in Bologna, where they present all the systemic manifestation of Behçet syndrome. So you can find here the optic neuritis, okay, and the uveitis. The posterior is much more common than the anterior. Okay. Which of the following suture material induce the least inflammation? The least inflammation. Surgical cut, Dexone, polyglycone, polyproline, or the silk? We want more participants. Well done to all of you. Yes, it's proline. So we have two types of the suture. We have the non-absorbable and the absorbable. The non-absorbable, the least inflammation is a proline. The most of it, it's a silk. So this is very important to know. Okay, and the absorbable one, the least of the inflammation is the PDS and the Maxone. Okay. Question 5, which laser is the most appropriate for a treatment of red tattoo? Alexandrite, carbon dioxide, erbium-YAG, frequency double Nd:YAG, or the ruby? Well done, yes, it's a frequency double Nd:YAG laser. As you see here, the black and the blue ink, usually you will treat them with the 694 ruby laser or the 755 Alexandrite or the Nd:YAG, the 1064. The red, yellow, and the orange, they all can be treated with the 532 double Nd:YAG laser. Okay, so you have to keep that in mind when you are treating patient with laser. Okay, question 6. Chlamydia trachomatis infection during a pregnancy should be treated with during pregnancy: doxycycline, erythromycin istolate, erythromycin base, ciprofloxacin, penicillin G. Well done. Yes, it's erythromycin base. So as you know, the chlamydia is a gram-negative bacteria. And the first line agent for chlamydia is the doxycycline 100 milligram PID for 7 days, or the erythromycin 1 gram, a single dose therapy. During a pregnancy, the first line treatment is erythromycin, but since erythromycin was not within the choices, so we'll go with the alternative choices, either amoxicillin or erythromycin. Amoxicillin as a dose of 500 3 times daily for 7 days, or erythromycin base as a dose of 500 Q4 times daily for 7 days, or 250 Q4 times daily for 14 days. Okay, so I have to keep that in mind. Okay, triangular lunula are a pathogenomic for a nail disease associated with Keratosis congenita, sorry, my voice is gone. Glotz syndrome or Derriere disease, nail patella syndrome. Well done, yes, it's nail patella syndrome. And as you know, it's a mutation of which gene, nail patella syndrome? Does anyone remember the genodermatosis? Yes, Lamix1B. That's correct, Dr. Michelle, well done. And is characterized by the limb and the pelvic skeletal abnormalities, the nail and the distal digital abnormality, and the renal disease. Okay, don't forget, this is very important, the Derriere changes of the nail, the longitudinal, the white and the red longitudinal bands, and the ridges, the splitting, the wedge-shaped subangular hyperkeratosis is very common, and the sandwich, what you call it, the sandwich of the red and white longitudinal band with a P-shaped neck of the free margin of the nail. This is pathogenomic for Derriere disease. Okay. Question 8, which viral agent has been implicated as a pathogenomic for Kaposi sarcoma? That's very easy. Epstein-Barr, herpes simplex, or human herpes virus 6 or 7 or 8? Well done. Yes, it's a human herpes virus 8. Well done. Which of the following is not correct about Treponema palladium? It has irregular tight spirals, limited capacity for DNA repair, inability to survive outside the animal host, can be cultured in vitro for an extended time period. It has periplasmic flagella. Well done, yes. We cannot culture a treponema, it cannot be cultured. So yes, well done. Marfan syndrome is caused by a defect in type 7 collagen, type 1, elastin, fibrillin, fibronectin. Well done, yes, it's fibrillin. Well done. Just remember the most specific feature of Marfan syndrome with the heart, with the aneurysm, mitral valve prolapse, affecting the lung with the pneumothorax, affecting the bone with the scoliosis, pectus extracavatum, and remember the sign, thumb sign, the wrist sign as well, okay? Okay, question 11. A 7-year-old female living in northern Eastern Australia present with a gross hematuria, generalized edema. She is diagnosed as glomerulonephritis. 4 weeks earlier, she developed a pruritic pink papule over the intratragenous region, the ventral surface of the wrist, and her lower buttock, and was diagnosed with scabies. Her mother noted that she has some lesion. A lesion had overlying a honeycombed crust. So she has glomerulonephritis, scabies, and the honeycombed crust. Which of the following is the most likely organism that caused this patient glomerulonephritis? Pseudomonas, Streptococcus, E. coli, Proteus, Schistosoma. Well done, Strept. You're absolutely right. Usually scabies can be associated with secondary skin infection, and they have a risk factor for an acute post-strep glomerulonephritis, especially in children. And the most common, they present with edema and hematuria and hypertension. And even it can progress even to kidney failure as well and kidney injury. Okay, and so this is very important to crucially, you have to diagnose scabies and treat it. Okay. No, Pseudomonas, it doesn't affect, it doesn't cause glomerulonephritis. Neither E. coli and the Proteus, they mainly affect UTI. Okay, and Schistosoma to the lower extent, but usually there is no association with the scabies. Okay. Okay. Which of the following is a true regarding oral ivermectin management for classic scabies? Treatment consists of one dose of 200 microgram per kg. It can be used in an infant weighing less than 15 kg. Clinical efficacy is low. Mass drug administration is successful in reducing scabies prevalence in high prevalence region. Treatment resistance is a common issue. Well done. Yes, mass drug administrative is successful in reducing the high prevalence region. So as you know that when you give oral ivermectin, you decrease the prevalence of scabies and you even decrease the impetigo prevalence as well. And you decrease the overall rate of acute post-strep glomerulonephritis. So you have to keep that in mind. So it's very important to start early. Treatment dose, usually it is 200 micrograms separated by, it's the 2 dose, not a single dose, by 7 to 14 days. Why? Because we have to kill the mite that hatch after the first treatment. So that's why we have to repeat it for the second dose as well. But the thing that there is no actual available data to give it for a children less than 15 kg. So we can, there's both safety and efficacy. We are lacking for the data, so we cannot give. Okay, and the cure rate is very high. It reached 90% for oral ivermectin. And it has been reported, so unless you've been treating the case for recurrent case repetitively with ivermectin, they may develop resistance, but usually an individual with the first time and the classic scabies, they don't cause any resistance. Okay, well done. We have 2 more questions. 55 years old Asian woman present with a 2-month history for pruritic violaceous papule over the metacarpopharyngeal joint for both hands. Several of the papule have been recently become ulcerated. The physical examination revealed no muscle weakness. Serological test is the most likely to reveal antibody to which of the following? TIF1, SAE, MY2, MADA5, NXP2. Okay, we get in between C and D. Okay, well, the correct answer is MADA5. I'll tell you why, because MADA5 has a vast majority of the patient because the symptoms is classically being described as amylopathic dermatomyositis and associated, because I give you the hint, development of the ulceration due to cutaneous vasculopathy. So that's amylopathic DM, okay? The other can be present in dermatomyositis, but they have a different kind of clinical presentation. So as of anti-TIF1 antibody associated with severe cutaneous disease and unique mucocutaneous finding, but no ulceration or amyopathic disease, okay? So there's no ulceration in TIF1. Whereas CAE antibody with severe cutaneous disease and progressive muscle involvement over time, okay? Both MY2, the one that you said it is C, and NXB, it's in the classical dermatomyositis, such as Kodachromes, papule, and all of this. But I give you the hint is ulceration. So ulceration is amylopathic dermatomyositis. So MADA5, okay? So this patient who have amylopathic dermatomyositis have a risk of developing which disease course? malignancy, interstitial lung disease, dysphagia, calcinosis, lipodystrophy. What do you think? I have a couple of answers. Yes, yes, it's interstitial lung disease. Okay, so they have a high mortality rate, over 50%, because of their high risk of developing interstitial lung disease. Okay, malignancy can be in any regular dermatomyositis, especially when they have an anti-TIF1 positive and anti-NXP2 antibody. Dysphagia is mainly with anti-TIF1 and SAE antibodies. Calcinosis and lipodystrophy, they are very rare in adults, to be honest, but you can see them in children with juvenile dermatomyositis. Okay, and usually you will see a positive NXP2 and anti-TIF1. Okay, last question. Which of the following peel require neutralization after application? It's quite easy. 30% glycolic acid, Gesner solution, modified Gesner solution, 30% salicylic acid, 1% tretinoin. I guess the rest is not that active. Okay, we're reaching the end. So yes, it is 30% glycolic acid. As you know, that glycolic acid is alpha hydroxy acid. It requires, among the peel that it require neutralization, the rest, the TCA and the Gesner doesn't require. Just to refresh your mind, with the Gesner solution, it composed of 40% rhizocol, 40% salicylic, and 40% of lactic acid mixed with ethanol, whereas the modified version of the Gesner have the citric acid in 8%. with the lactic and salicylic in 17%. Okay, and this is the end. Thank you so much. Hope you like the quiz, but this time actually we have lots of answers and most of the answers were really fascinating. So we'll see you next meeting. Goodbye, everybody.